Many people actually refer to this drug as a game changer. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today I just want to dedicate an entire video to this drug that's known as Paxlovid, which is a drug that has been approved by the FDA for treatment against COVID and in certain groups of individuals. We'll talk about that in a lot more detail. So if you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. Tell a friend to subscribe, drop a comment, drop a like, grab a piece of paper, and let's go. So before actually going into a whole lot of details, I'll just remind you a little bit about COVID-19. I did a separate video on COVID-19 way back on the channel. And if you haven't yet watched that, I will leave a card right here that you can click on and go watch that video. And pretty much, what is COVID-19? It's going to be an enveloped virus. It is single-stranded, positive sense RNA, and it's going to affect the respiratory system. It's going to affect the gastrointestinal system. It's going to affect the central nervous system of many species, humans included. Now, the COVID-19 has four main structural proteins: the membrane glycoprotein, which is known as the M protein, the envelope protein, which is known as the E protein, the nucleocapsid protein, which is known as the N protein, and the spike protein, which is the S protein. So as you can see here, you have this yellow depiction here, which is the envelope protein. This, of course, these are your spikes. Then this is, of course, your membrane protein, and you have your lipid like that. So this is the structure of COVID-19. Keep this in mind. Very, very important. These four proteins, very, very important in the replication, in the transmission of COVID-19. So now, before we actually go into details of the drug, it is imperative to actually understand the life cycle in detail. In my previous video on COVID-19, I didn't dive so much into the life cycle because there was a lot that I had to cover. But here, I won't be covering so much, so I will be able to dive into a lot more detail than I did in the previous video. So remember that, first of all, the virus is going to be binding to a receptor by its spike protein, the S1 subunit of the spike protein. And depending on the type of virus that you have, it binds to different types of receptors and different types of tissues. For example, the alpha coronaviruses usually have an inclination to bind to the aminopeptidase N receptors, while as the SARS-CoV-2 viruses, the other viruses tend to bind to our angiotensin converting enzyme 2 receptor. Then you may also have other types of viruses that may bind to other different types of receptors, but I just want you to focus on the angiotensin converting enzyme 2 receptor. So now, after this virus is now bound to this receptor, then you're going to activate certain types of proteolytic activity to happen, and acid-dependent proteolytic cleavage is going to happen. So the S protein is going to be cleaved into two subunits. It's going to be cleaved into an S1 subunit, and it's going to be cleaved into an S2 subunit. Then this is going to be done by many different types of enzymes like furin, cathepsin. You may also have your transmembrane serine protease 2. You may also have other proteases that can actually cause this cleavage of the S protein into the S1 subunit and the S2 subunit. Then after this has happened, you're going to have the S2 subunit actually facilitating the fusion between the viral membrane and the cellular membrane. And that's how actually the virus actually deposits itself into the cytoplasm. Now remember that when you release this viral genome, this genome has to be translated. And it attaches to a ribosome and it has to be translated, and you make proteins, you make your nucleic acids, and then eventually you assemble this. But before all this thing is happening, remember that there is a very, very important enzyme that is needed, which is known as our main protease enzyme, or you can say the MPRO3CL. This is our main protease enzyme. Now, this enzyme is very critical in the life cycle. I'll show you a picture just after this because it actually gives rise to non-structural proteins which are crucial in the genome replication, that are crucial in making viral particles that are infectious, those that are functional. So it's going to be resulting in making of enzymes like an RNA-dependent RNA polymerase, a helicase enzyme, ribonuclease enzyme, and also even another main protease enzyme. And if these enzymes are not found inside the COVID-19, it won't be a functional virion. So it means that it's not so easy to infect another type of cell, so it's rendered ineffective. Now, what does this main protease enzyme do? The main protease enzyme actually is going to cleave the polyproteins into, or the polypeptides into, two types of proteins. You have the polyprotein 1A and you have the polyprotein 1AB. These are the ones that are going to be responsible for synthesis of these non-structural proteins. I'll show you a picture and it will make a lot more sense when I do this. So the maturation of the virus is dependent on the cleavage of the large polyprotein 1A and even the polyprotein 1AB. And this is done by two main enzymes. You have the main protease enzyme and the papain-like protease enzyme. So these are the two enzymes that cleave this polypeptide. Then after all this is happening, you also synthesize some viral RNA and you assemble the viral replication transcription complex. Then once this has been assembled, you're also going to be assembling some of the structural proteins such as the S protein, the E protein, and the M protein. And these are obviously going to be inserted into the rough endoplasmic, or rather the endoplasmic reticulum, and then they move from the endoplasmic reticulum into the Golgi intermediate compartment, a complex which you call as an endoplasmic reticulum Golgi intermediate compartment. And then you also have multiple copies of the nucleocapsid proteins that are packaged genomes of RNA into these helical structures, which we call as your ribonucleoprotein complexes. This happens in the cytoplasm. Then, of course, these can interact with our hydrophobic M proteins, which is an envelope protein or a membrane protein, and this is happening in the endoplasmic reticulum Golgi intermediate complex, and therefore assembling the viron. So in short, you're making the viron, and then the viron is going to be released by a constitutive pathway of exocytosis. So in short, exocytosis. This follows the normal schematic of viral replication. So here's a picture that I was telling you about. So you see here, you have binding of the virus and viral entry of the membrane via a process of endocytosis. Remember that this receptor here is going to be our angiotensin converting 2 enzyme receptor. This is going to be a spike protein interacting with this. Now, the spike protein is going to be divided into 2 subunits by activation of certain protease or acid dependent proteolytic activity, which is going to be catalyzed by different types of enzymes that are eventually going to cleave the spike protein into the S1 and the S2 subunit. Then the S2 subunit will facilitate the fusion of the membrane of the virus into your host genome, and this is actually going to release the viral genome into the cell. And remember that this is a positive sense RNA, so it can actually be read just like your normal RNA in your body. So one of the big players is actually your viral polymerase, your main viral polymerase that's going to be actually translating the viral polymerase protein. And then, of course, there's going to be some RNA replication that's also going to be taking place. And remember, there is a very important viral polyprotein, which is your PP1A and your PP1AB, which are eventually supposed to be cleaved off from each other. And eventually, this is going to result in synthesis of your genetic material, synthesis of your structural proteins. So pretty much your nucleocapsid, your spike proteins, your membrane proteins, and your envelope. And remember that the spike proteins, the membrane proteins, and the envelope proteins are synthesized from the endoplasmic reticulum, and then the nucleocapsid is going to be interacting with the viral genome in the cytoplasm, and all this complex is going to be packaged in your endoplasmic reticulum Golgi intermediate compartment, and then obviously this is going to be released by exocytosis. So we can actually give a drug that can inhibit the cleavage of this protein, the viral polyprotein, and remember that the enzyme that is going to be responsible for this is your main protease enzyme, and we now have a drug that can work against this. So the drug that's known as Paxlovid is actually an oral antiviral drug that was developed by Pfizer, This actually, according to the clinical trials, has been shown to actually reduce the risk of severity by 89%. That is very, very high. There is another pill that's developed by Merck. I don't know if I spelled that or I pronounced that right, or I butchered the name, and that's the name of the drug. I will not attempt to pronounce this. And it also has been approved by the FDA to be used in COVID, but it only reduces the risk of hospitalization and death by 30%. As you can see, Paxlovid is actually much more superior as compared to this other drug. Then, of course, Paxlovid shows an efficacy against even the Omicron variant, and it's going to be a combination of two drugs. Nirmatrelvir, I believe that's how it's pronounced, Nirmatrelvir. This is a very, very complex word to actually look at, and ritonavir. So this has actually been approved for patients that have COVID that are either 12 years and above and at least 40 kilograms. I just round this off to 40 kilograms. 40 kilograms, and they have high risk of severe disease. Now, there are some considerations of prescribing and dispensing this drug. I will talk about that. And this is a game changer because we can give this drug orally. So this drug can be given orally. So remember that the other drugs are usually parenteral, like your remdesivir, your other immunomodulators. Those were oral drugs, and they were modulating the immune system. They weren't really having effect against the virus itself. They were rather hushing down the immune system so that you do not have these excessive reaction from the immune system. So what's the mechanism of action? There are two drugs, nirmatrelvir as well as ritonavir. So nirmatrelvir is actually an oral bioavailable protease inhibitor. Remember, this is going to be inhibiting your main protease enzyme. And remember that this viral protease enzyme is very important in viral replication because it's going to be cleaving the two viral polyproteins. That's, remember, your PP1A as well as your PP1AB. And then, of course, remember that if this cannot happen, the particles that you synthesize are going to be non-functional. So it means that the cells are going to release virion particles that are not able to infect other cells, are not able to replicate. And the reason why we're adding ritonavir, remember that ritonavir is a strong cytochrome P450 3A4 inhibitor. So it actually, we used it way back as part of the HIV regimen, but now we use it to boost the concentrations of other drugs. Let me explain. So suppose you have a drug like nirmatrelvir, which pretty much is going to be metabolized by cytochrome P450 3A4. It would mean that if you give this drug alone, remember that there is a concept that's known as bioavailability. The bioavailability of this drug is going to reduce. What do I mean? The liver is going to break down some of this drug and change its structure in some cases, or reduce the effective concentration of the active ingredient reaching the blood. Suppose you give 50 molecules of a drug and only 25 of the active substance reach the bloodstream, then that drug has a 50% bioavailability. That's like the simplest way I can explain it. Now, what do? We can give a drug that's now going to inhibit this enzyme that reduces the bioavailability of this drug, such that we can get much higher concentrations of the drug in our bloodstream. That's the rationale behind us using ritonavir. Even just in the HIV-based regimen that I've been covering on my channel, I have been stressing about this. Ritonavir is used to boost the levels of other drugs in the bloodstream. So it's a cytochrome P450 inhibitor. So we usually co-administer these drugs because the ritonavir is going to increase the concentration of nirmatrelvir inside the blood to the therapeutic levels that we want. Then, of course, what is going to be the dosage? This person should take the drug within 5 days of developing symptoms. And they can actually take the drug even on an outpatient basis. And it works best when you start the drug actually early during the course of the disease. But remember, you must get a positive COVID test. You must be within 5 days of the symptoms. You must be at least 12 years. You must be at least 40 kilograms. And you should have certain significant risk factors such as other underlying conditions like cancer, diabetes, obesity, even age above 65. Even pregnancy actually is considered as a risk factor for severe COVID disease. So this drug actually is safe in pregnancy because we do still use ritonavir-based regimens in HIV management. So this drug is safe in pregnancy. So what's the dosage? We're going to be giving nirmatrelvir 300 milligrams and ritonavir 100 milligrams orally twice a day for 5 days in non-hospitalized adults and even pediatric patients that are above the age of 12 and those that are weighing greater than 40 kilograms. Now remember that because you have ritonavir inside this combination, there are going to be significant drug-to-drug interactions. If you want a really detailed explanation, especially with the antivirals, I'll leave a card here to our interlude of HIV where you can actually go and watch that video. So actually, before you prescribe these medications, it's very important to review the drug-to-drug interactions. I'll give you a list of drugs that can be administered with this drug and those that you should administer with caution and those that you can't. So because remember that the ritonavir is going to be a very potent inhibitor of your cytochrome P450. And so this can actually happen very, very rapidly, especially you get this maximal inhibition when you have been given this drug in the first 2 days. So in the first 2 days, there's maximal inhibition. Then after you discontinue ritonavir, 70% to 90% of the inhibition is going to resolve within 2 to 3 days. So the time of resolution actually varies based on certain factors. It could be based on age. It could be certain individuals take longer to resolve than others. In the elderly, they take much longer to resolve. So when we use the ritonavir for 5 days, the induction properties are less likely to be clinically relevant when the drug is used chronically, because if you use it early on enough, there's going to be significant inhibition of the cytochrome P450. Then, of course, this is going to be in patients or in the background of patients that we are managing for HIV. So remember that both these drugs are substrates of cytochrome P450. So the ritonavir boosted nirmatrelvir should not be given within 2 weeks of administration of another drug that is a strong inducer of cytochrome P450. The best example that I can give you is rifampin, which is used in the treatment of TB. So it means that you don't give these drugs together. So it's going to be contraindicated in these settings, and I will give you a list of drugs, and an alternative should be used to the other drug, or you can actually use other different regimens in the management of COVID-19. So what are the side effects? Usually they're not so severe, but you may get altered or even impaired sense of taste, which is called dysgeusia. You may get diarrhea. You may get increases in blood pressure, muscle aches. And remember that these drugs are excreted by the kidney, so they require some dose adjustments, especially in patients with mild to moderate kidney disease. Those that have end-stage kidney disease, it's not yet recommended that we give them this drug. So if someone has an estimated GFR of 30 to 60 mils per minute, then we can reduce the dose to 150 nirmatrelvir and 100 milligrams of ritonavir twice a day. That's in mild renal impairment. Anyone less than 30, it's not recommended. This drug is contraindicated in patients that have severe or suspected severe hepatic involvement or hepatic impairment, a Chart-Berg score of class C. Those that have pre-existing liver disease, liver enzyme abnormalities, or even hepatitis, this drug should be used with caution. Now, what are these drug-to-drug interactions? Let me just explain what a drug-to-drug interaction is in the simplest or the best way I can actually explain this. Suppose you have two drugs, drug A versus drug B. If drug A induces an enzyme that breaks down drug B, it means that this is a drug-to-drug interaction. The drug A is affecting how drug B is working and how much concentration of drug B you're getting in the bloodstream. So it means that if it reduces the concentration of B, if you co-administer these drugs, you'll find out that B will not be as effective. That's one way in which a drug-to-drug interaction can play out. The second way is if drug A is an inhibitor of an enzyme that's supposed to break down drug B. So it means that if you co-administer this drug, the side effects of drug B will become now potentiated because you now even have more concentration of this drug in the bloodstream. So remember that boosting with ritonavir is actually a strong cytochrome P453A inhibitor and a P-glycoprotein inhibitor. So it's required to increase the exposure of nirmatrelvir to a concentration that is actually effective for SARS-CoV-2. But this also can actually work with other medications that are metabolized by the similar enzyme systems. So remember that ritonavir is an inhibitor, an inducer, and even sometimes a substrate of various other drug metabolizing enzymes and other drug transporters. So there's a various drug-to-drug interactions. I'll show you how to identify them. So how do we identify these drug-to-drug interactions? So pretty much if you're prescribing this ritonavir-based regimen and this person is taking some over-the-counter medication, herbal supplements, recreational drugs, then you can do one of the following things to see if there is a drug-to-drug interaction. So there is a quick reference list that I will give you. Box 1 are pretty much the medications that are prescribed as outpatient. They do not have any significant interaction with this Paxlovid. Then box 2, these ones have a clinically relevant drug-to-drug interaction with this based regimen. Then a second way is that you can check the web-based drug-to-drug interaction checker, the Liverpool COVID-19 drug interactions website. You may also check the tables with guidance on management of specific drug-to-drug interactions in the COVID-19 management guidelines, the Ontario COVID-19 Science Advisory Table, the Food and Drug Administration Emergency Use Authorization Fact Sheet, and even checklists for ritonavir-boosted nematrelvir. Then, of course, you should also consult an expert with this, a pharmacist, an HIV specialist, a patient specialist providers. You should consult them and see whether this drug can actually cause toxicities with certain other drugs like anticonvulsants, anticoagulants, antiarrhythmics, chemotherapeutic drugs, neuropsychiatric drugs, and even immunosuppressant drugs. These are the common groups that usually have a lot of drug-to-drug interactions. So here are a list of the drugs that do not have relevant interactions. So I will leave this on your screen for a few seconds. You may actually pass through the drugs and you can actually screenshot this. It's going to be very helpful to you and you can actually go through this. Then what's our management strategy if you get a drug-to-drug interaction? So there are certain things that you can do. So first of all, you should consider the magnitude and the significance of the potential interaction, because this will help you choose what you're going to be doing next. You may temporarily withhold the concomitant medication administration. You may increase monitoring of the potential side effects, especially if there is an increase in the side effects of this drug. Then, of course, you may sometimes adjust the dose of concomitant medication. You may sometimes use alternative concomitant medication or even an alternative COVID-19 therapy. So use the chosen strategy for the 5-day duration of you giving this Paxlovid, and then, of course, for at least 2 to 3 days after completion, you should also continue with the same regimen. Then you can switch back or revert back to what the patient was taking. Now, these are the drugs that pretty much have significant clinical drug-to-drug interactions. As I said, anticonvulsants, anti-infective agents, immunosuppressives, cardiovascular agents, neuropsychiatric agents, pain medications, pulmonary hypertension medications, even other miscellaneous drugs. And please note these annotations that we have here. I'll show you another aspect, another table at the end of this that is quite significant with this and explains why I'm adding these annotations to certain drugs. Then, of course, you may temporarily withhold concomitant medication if it's clinically appropriate. So you may actually withhold the medications during the treatment with your ritonavir-based COVID-19 treatment. So pretty much you're going to be withholding the treatment during the 5 days and for at least the 2 to 3 days after the treatment is complete. Then you can reinstate these other treatment. These are just some of the drugs where you can do this. Then these are drugs where you just have to adjust the dose and monitor for the side effects. Most of these is because the drug itself actually increases their toxicities in the bloodstream. So you can also just take a screenshot of this. It's very self-explanatory. Then these are drugs where you continue the concomitant medication and you monitor for adverse side effects. And this is the table that I was telling you about with those annotations based on the drug. So you can just have a screenshot of this, and I believe it's actually quite self-explanatory and even has the abbreviations at the bottom there. So there is something that's known as the rebound effect with Paxlovid. where there has been some reports actually when the clinical trials were done. There has been some reports that individuals that actually did complete the 5-day trial of the drug, they actually did get symptoms recurring about 4 to 5 days after completing the treatment. But of course, what Pfizer actually reports is that they even saw this appearing, or they postulated that this would appear roughly around day 10 to day 14, or day 10 or day 14 in patients. But what was surprising is that even this happened in patients that did not even receive the drug, the Paxlovid. So in June, actually, the CDC actually released the guidance for clinicians, and they say that this was just pretty much attributed to the natural history of the SARS-CoV-2 infection, and it was independent of the treatment with Paxlovid, and there is no evidence that the additional treatment is actually needed. Then there is Dr. Roberts, who is an infectious disease specialist, that actually said that the hypothesis is that we have the immune system that didn't have a chance to see the full extent of the virus, and since Paxlovid is suppressing the replication early in the disease, that's why we tend to see this rebound effect later on. So for anyone who actually experiences the rebound effect, they should actually notify the Pfizer through their portal for adverse events associated with Paxlovid. Now, you also have to take note that even though it has high efficacy of 89%, it's not perfect. And even if it was perfect, the viruses tend to mutate. The drug can be resistant in a few days, in a few months, in a few years. And some patients will be hospitalized because the medication is not perfect. But for those that are hospitalized, it will reduce their risk greatly of actually passing away. But always remember, it is important to get vaccinated. If you haven't yet gotten vaccinated, please get vaccinated. I also did a video about vaccines. You can check it out here. And after you watch this video, thank you for spending your time to listen to this video of Paxlovid. If you loved it, please consider subscribing. Hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a comment, drop a like. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.